And what I'm talking is, okay, what is the subject? Approach to bereavement care.
It's an approach to bereavement, yeah.
So what are the highlights that you would like me to introduce? That you're a, how do I pronounce it? You're a lieutenant. Lieutenant.
Yeah, lieutenant, yeah.
Okay, good. Okay. Lieutenant Alice Stella Virginia. Sounds very good. Okay. So where did you serve the army?
Secunderabad, Jhansi, and then in Nagpur.
Okay. So after that, you came to Calicut when we met.
No. After once I left, I went abroad. I worked for quite some time in abroad also. Then
Where
I
was
came back. 2000, I joined. 2000 joined. I joined. Uh, in 2002, I joined in Calicut.
okay. So after that, you went and joined the army.
No, I joined in 1983.
Stella, you look so young. I would take you to be on par with my children. Huh?
1983, I joined.
I stand corrected. Okay. So it's after your army service that you joined Calicut, is it?
Yeah. After my army service, I joined Calicut. Since 2007, actually, 2006, I became a permanent staff, and then I started in palliative care. So there
But
was
you
a
retired, it
deputation.
seems you retired in 2020.
Yeah, 2020, I retired.
So then from 2002 to 2020, you were still with the army?
No. After leaving army only, I joined the government service in Calicut.
Okay.
Then I left 2020. I got retired from Calicut Medical College,
Oh,
and since then, online, still offline training programs for most of the organizations I'm doing. DNIP Care, Pallium India, I was doing for CIPLA, IAPC, IPM, then running about also. Number of times I've gone to many other states also.
but you're grounded now at Bangalore because of one person.
No, so yeah, since 2023, I am in Bangalore only. Up and down, I'm doing from Bangalore only. And after her delivery, then I thought again up and down. So next month, I'll be back to Calicut because her in-laws are coming here.
Yeah.
So they'll be staying for some time, so I can be back. So in my absence, my husband takes care of him. So it's okay. So, yeah, 21 people have joined. So 21 means almost 20 people have joined.
Yeah, I'm ready to start. എന്ത് പറയുന്നു
മാഡം ഒരു 2-3 മിനിറ്റോടെ നമ്മൾ സാധാരണ ഒരു 40 ഈസ് ഒക്കെ അറ്റൻഡ് ചെയ്യാറുണ്ട്. ജസ്റ്റ് ഒരു 2-3 മിനിറ്റോടെ വെയിറ്റ് ചെയ്യാം.
Okay, Shiva.
അറ്റ്ലീസ്റ്റ് സെഷൻ തുടങ്ങണ വരെ എല്ലാവരും ഒന്ന് ഫേസ് പ്രസന്റേഷൻ ചെയ്താൽ അങ്ങോട്ടും ഇങ്ങോട്ടും നമുക്ക് ഒരു ആരാ എന്താന്നൊക്കെ ഒന്ന് അറിയൂലോ. ഹലോ എവ്രിബഡി.
The Shiva തന്നെ വന്നു. Dr. Salim PK, Dr. Sarlovali.
ആരാ കടമ്പഴിപ്പുറം? ഡോക്ടറെ പേരെന്താ?
ആരാ?
കേൾക്കില്ല. മ്യൂട്ടാണ്.
ആനന്ദം. ഹായ് ഗീത, ആനന്ദം.
I've seen you. I saw you. I could recognize you immediately.
Okay.
Dr. Sornavalli. ഇപ്പോഴാണ് ഞാനത് ശരിക്കും വായിക്കാൻ തുടങ്ങിയത്. ഇതുവരെ സോണാർ എന്ന് ഞാൻ വായിച്ചിട്ടുണ്ടായിരുന്നത്. സ്വർണവല്ലി എന്നാണ്. ജിംഗിൾ സേവിയർ, ശരിക്കും പേര് തന്നെയാണോ? അതോ ഇതിലേക്ക് വേണ്ടി?
അതെ അതെ.
എവിടെയാ വർക്ക് ചെയ്യണ? ജിംഗിൾ സേവിയർ.
മാഡം, ഞാൻ ചേർത്തലയിൽ ഒരു പ്രൈവറ്റ് ഹോസ്പിറ്റൽ.
ഓക്കെ. അല്ല, പാലിയേറ്റീവിലല്ലേ?
അല്ല മാഡം.
ഓക്കെ. വെരി ഗുഡ്, വെരി ഗുഡ്. വെൽക്കം, സ്പെഷ്യൽ വെൽക്കം.
താങ്ക് യു.
ശിലാജി, സ്ലൈഡ് ഷെയർ ചെയ്യാൻ പറ്റുന്നുണ്ടല്ലോ അല്ലേ?
ഉണ്ട് ശിവ. ശിവ വീട്ടിൽ നിന്നാണത്?
അതെ ശിലാജി. നമുക്ക് ജസ്റ്റ് സ്റ്റാർട്ട് ചെയ്താലോ ഗീത മാം? ജോയിൻ ചെയ്യുന്നോട് ചെയ്യട്ടെ. മാഡം ഇൻട്രൊഡ്യൂസ് ചെയ്ത് തുടങ്ങി.
പിന്നെന്താ, ഓക്കെ. അപ്പൊ വാം വെൽക്കം. ഇന്ന് ശരിക്കും വാം വെൽക്കം തന്നെയാണ്. മഴയൊക്കെ കഴിഞ്ഞിട്ട് ഇന്ന് ഇത്തിരി വാം ആയിട്ടുള്ള ദിവസമാണ്. സോ വാം വെൽക്കം, ഗുഡ് ഈവനിങ് to all the participants of this monthly online Zoom session on palliative care. Today's subject is bereavement care, and we have the most appropriate person speaking about it. It's my pleasure and privilege to introduce to you all Mrs. Alice Stella Virginia. And what is very special about her, it's not every day that we have a retired army person. She has a long service, I think, of serving in the army, and 38 years of experience in India and abroad. A full resource person after her retirement. So she came to Calicut after her retirement from the army, and then she retired from IPM Calicut by May 2020. But still full of vigor, charisma, and energy, all loaded on one person. And she's continuing online and offline palliative training for doctors, nurses, volunteers, campus students, and patients, caregivers, which is a very important aspect when we come to this particular topic of the evening. She has been a resource person for development of a facilitator guide and a training manual and training schedule for training the doctors, nurses, community health workers under NNPC NHFIW New Delhi. Compiled a modified manual for the BCCPN. Oh, great work. Published in 2014. And she has sent her contributions for different textbooks of palliative care, doctors, nurses, and volunteers. And she has been cited in one of the international books for children's palliative nursing care. It's quite wonderful. Her accolades are many, out of which I might mention a few. Certificate of Appreciation as a nursing in charge of Buka Hospital of Oman for playing effective role to improve the quality of healthcare rendered to the community in 2003. Best Nurse Award given by IMA Kozhikode 2014 to 2015. International Award winner for palliative care 2019-2020. Award for Excellence and Leadership in Palliative Nursing given by Cancer Aid Society, Lucknow. Also, her recognition is as a national leader from India in 2020 at the International Year of Nurses and Midwives and was launched on World Health Day, April 7, 2021 by IC10, WHPCA and IAHPC. And now we come to the most important topic, the End of Life Nursing Education Consortium, Project City of Hope, American Association of Colleges of Nursing presented her with ELNEC. Though we are not very sure about the full form of all these appreciations and medals, we know it's so befitting you. So a warm welcome, and I hand over the mic to you. Thank you, Stella, and thank you all the participants. Please now all ears for this wonderful speaker.
Thank you so much, Dr. Geeta and Shiva, for giving me this opportunity to talk to our doctors. Before sharing my PPT, I would like to say, equally, all people must have seen grief, loss, and bereavement in your life, in your work also. I'm going to just highlight some things which may click in your mind, that we also can do many things as doctors. And it's not that easy, I say. It's not that easy. It's very difficult because I too have went through these things in my life. I know very well my parents, my beloved, some. So it's not that easy. But still, as a healthcare provider, at times, we need to know also how we can be a support to others. So I'll just share my PPT, and towards the end, I would like some of you to also share your experience, which will inspire others. So bereavement. So usually I would like to start an activity. If not, you people not having a paper also, just think. Can you write a short note to one of your patient's close relative who have left this world during one of your shift? You can just think also in your mind, if you see such a person, what you will talk to them. As I told you before, it's not that easy. So before going into bereavement, these things are very important. Loss is the absence of a possession or a person, because it is something that no longer we are holding it. And if it is through death, it is permanent. And grief is the natural and normal emotional response to loss. When there is a loss, we grieve for that. And I would like to say, before the loss itself, we start grieving. And mourning is something which we show outwardly. That's the social expression of loss. Some may cry out so loud. Many things happens. You must have seen how people react to the loss. Now, in bereavement includes grief and the mourning, because it's a reaction of the survivor to the death of a family member or close friend. So the period after loss during which grief and mourning occur, whatever it is, This is strongly influenced by culture. Culture is very, very important. I always keep in my mind that whatever we do, if it's in palliative care or not in palliative care also, culture is very important because we have a different cultures. So that is also very important. So when we talk about bereavement, which refers to a comprehensive emotional, practical and spiritual support, which is provided to the individuals and their families who are experiencing the loss of a loved one. And we help them to navigate the grieving process. That's all. So it includes, when we talk of bereavement, it includes support before, during, and after a death. So it offers counseling, support groups, resources, and of course, practical assistance to manage the emotional and the life changes that accompany the loss. So when we talk about a bereavement, I just cannot talk a bereavement because bereavement comes to the end. Before that starts the grief. So it should be before, during, and after death. So let us just have a look at that. People have made a lot of attempts to understand what is grief through the ages, but still not able to fully understand. So as a healthcare provider role, we should assess the grief, assist the patient with grief, and support the survivors. So there are different approaches to loss, grief, and bereavement. Different models are there. I'm not going into these theories of grief and bereavement. If you all have time, you can just go through. Freud, you can see Kubler-Ross, Parks and Weiss, Borden, and Bowlby. Okay, these are different types of the theories they have said. But what is common in all these theories was common beliefs underlying the earlier grief theories was the journey through the grief occurs in predictable stages. That's what they say. It goes in a predictable stages. Grief work is freeing oneself from the attachment to the disease. Someone has died. We get this one, free ourselves from them. And grief work leads to recovery from loss and moving on. So what happened was a new perspective on the process of grief and because when they have made these models, one thing what they thought was this is not a normal thing. Okay, something different should be there. So reaction to loss varies considerably from person to person. That's the first thing. It is different from person to person. You cannot predict. Not everyone passes through the stages as expected. These, whatever theories are there are stages for that. And you cannot expect that we will go step by step. And there is no fixed final stage of normalization in grief. We still grieve. We must have lost our parents years before. But still, sometimes we think about them. We feel that loss. And at times, even tears will come when we think about them. So, never think it is going to be a normal this one. It will be normal, but throughout our life, we will be remembering that. And grief is not a linear journey from anguish to recovery also. Okay, so you don't get over it, you get through it. How beautifully it is written. It doesn't get better, it gets different. Every day, just like me, grief puts on a new face. See, people have written many things, and the Kubler-Ross has written, the reality is that you will grieve forever. You will not get over the loss of a loved one, but you will learn to live with it. See, that's beautiful. So, grief is like the ocean, it comes in waves, ebbing and flowing. Sometimes the water is calm, and sometimes it is overwhelming. All we can do is learn to swim. So that is grief. So we learn to swim in that grief. So the recent research transforms our understanding of grief and bereavement. There's a complex process of working through that. Grieving does not require moving away from the deceased. Nothing like that. And continuing the relationship with the deceased despite their physical absence. And in fact, it helps the grief process to make it more easier. And of course, the absence of grief no longer seen as a pathological. Previously, people used to say that if we grieve, it is something is wrong with us. But it's not like that. Normally also we can grieve. So it's not pathological. So where again newer models taken, these are some newer models. So grief as a transformative process, when we say loss can lead to growth, acknowledging the loss, immersing in the grief, searching and seeking new meaning, identity, purpose can provide sources of strength and hope. See, loss can lead to growth. Very true. Second, acknowledging the loss and immersing in the grief, searching and seeking new meaning. And it can transform the person and the world they live in. Because usually we try to adjust to that process. Once we have that loss, we try to transform ourselves. So these are the theories of grief, that is relearning the world, relearning the physical surroundings, social surroundings, aspects of the self, the relationship with the deceased. So these are theories of grief. So let us see this. Grief starts before the death and it continues after the death also, and not orderly or predictable. Includes a series of stages or tasks is there in the grief. And remember, no one gets over it. Grief work leads to living with the loss. Yeah, it works only when we start living with the loss, and healing occurs when the pain is lesser. So these are the grief process. So there are different types of grief. Something like anticipatory grief, from the heading itself, anticipating grief. Okay, before the death of a person, see, patient and the family grieves. Okay, it's not that the patient doesn't grieve. As soon as the patient comes to know about the diagnosis where he is in a life-threatening illness, he starts grieving because he sees his death before him or her. Okay, so with that, the family also grieves. This we have to keep it as an important thing. Now, anticipatory grief includes many of the same symptoms of grief after the loss. As I told you, before and after, it goes like this. So there can be depression, lot of heightened concern for the dying person. It can be mental rehearsal of the death, for both the patient and the family start rehearsing in their mind that after this the death will be like this may happen, this will be doing, a lot of things goes in their thoughts, and attempts to adjust to the consequences of the death, and they try that how to get adjusted to that. So you see, before death only it starts, both the patient and the family. Now, some aspects of the anticipatory grief, because this grief process really affects the bereavement period also. Despite a period of anticipatory, the survivor can go into a grief state. Don't think that patient family is being grieving before. Soon after the death of the family, they will get relieved. Or sometimes actually feel a sense of relief after the loss. How some people I have heard saying, he was in very pain, but now he is relieved from everything. Okay, so that pain, which even the family, the family experience, okay, they say that now everything is finished. So there is a relief. May feel less devastated by the loss and so feel guilty also sometimes. And then the death is after a protracted illness with many ups and downs prior to, the family actually wants to get on with their life. This also can happen. So let us say in India, if we say not only India, in some most of the many places, there are some days of mourning. After a person is dead, this many days all will be at home, they are sitting and crying, they'll be talking, they have a lot of rituals to do. These things happen. So a lot of things are being done. Again, value of mourning, the rituals. One thing is is seeing the body. I don't know how there is when we talk about the culture, only in some culture it is allowed to see the body of the deceased person, and even some of this one religion, they don't allow them to go into the graveyard, also cemetery and all. Okay. Another thing is touching and kneeing. Okay. In many of the customs or culture, it is the go touch the body for the last time, kneeling before them, kissing the body. This all. Another thing is telling and retelling the event story. That's the backstory. Okay. Again, in the it happens usually in the bereavement type on time, that when people get gathered together, the family starts telling the stories of the person who is deceased. That is one way of getting expressing their grief, expressing whatever was there in their inside, and how they get adjusted to the next life. Presence of the family and the kinship is very important. Yeah, in India, people all get together when there is a death, mostly. Some people bring food. I remember when my dad passed away, even my mom passed away, for 3 days, food was brought by the neighbors. We didn't have to cook at home because we all were grieving. So that is something. Praying together, that is something. Again, people sit and pray together when a death is there. And after the death also, they all sit and say the prayers. And of course, the monthly rites for a year and subsequently annual rite, like we keep every year, we do some prayers, we give some alms to the poor, or some charity work some people do them. These all are the things which helps us in a bereavement period. And in addition, the palliative care team can help us provide continuing of relationship that started before the patient's death. So in palliative care, after the patient death also, we go visit the family member. And that is one of the best things which I found was how they explain to us what has happened, where the patient died, who all were present. And during that days when he was at home, what all they have done, and how was the patient, so many things. Okay. Acknowledge the need to extend the reliving of the shared experience of the patient's care. And of course, our presence. Presence is very, very important, because we all learned communication and we say, listen to them. They will have a lot of things, good and positive and negative, and both are there. Okay, so we need to sit and listen to them so that they can pour out everything, whatever is there in their heart. And accompaniment. Okay. Now, intervention. Usually this doesn't happen in India and all. In some Western countries, they do have. But of course, in India also, in some families or some places, this happens. I won't say place. Some families, they do. Keeping some precious things that the deceased person has given for their memory, we keep it somewhere. We always keep seeing that. Some people say this pen was my dad was using this pen. This is my mom's sari, or this is my dad's coat, something memorable things. Even pictures, old photos. Okay, that's all are memorable. Okay, when we were child with our parents or something like that, that pictures, which keeps us, gives us a lot of, gives us a lot of support, I should say, mental support. It's like writing letter to someone close. So if I say that, nowadays nobody's writing letter. Okay. If you ask me, I have still my dad's letter when I joined. That was the first time when I had left my home. When I was in army, he used to write letters to me, my dad and my mom. So a lot of letters I am having, which some precious letters of my parents, my friends, very close friends, my sisters. I had kept it. So when I just, it's kept in a file, like I filed it, right? So when I see that, I remember my dad's signature. Okay. See, that's all very precious. So in a bereavement also, usually it should start before. It's very important. So I would like to share one thing. I remember one patient, uh, CS stomach was in very bad pain, and wife and two children, they had come. And while talking, the wife told me that why to live like this? It's better to die because of pain. And I remember I told them, we can take care of your pain in palliative care. Okay. And I asked a question also to them. You people have decided to die, but what about your children? I asked. You know what that wife told? She said, I have never thought about the children. I was just thinking about my husband and myself. Okay. So anyhow, the patient was admitted in palliative care. That pain was taken care of. I asked her a question. Again, I asked her if something I can do for you. She just told me that she wanted a family photo. She said there is no family photo. Okay, all four of us. And since the time my husband was not well, I asked for it and he refused it. Same. So I had a very close friend of mine who helped me in this. She took a photo of these people unknowingly. That is another thing. Unknowingly, in the sense, she had visited IPM, and before that, she told the patient's wife, you just bring him out. And while taking some photos, IPM is very beautiful. So I'll be taking some photos. That time, I'll take a photo of yours. I will ask the permission, I'll take. So she did the same thing. She just asked, can I just take a photo with your children? And he agreed and have taken. And I remember after his death, when she had come after a long time for her children's educational support, she told me that picture which was taken is the only one thing which I have and which I remember was done in a very good way. Okay. So things are there like that, which will, and writing to someone else about our pain in the heart of the loss and how we are grieving, that also will, it's a one way of ventilating our, this one, sorrow. Okay. That's a normal grief. It's a very normal, no complication. Normal feelings will the behaviors and reaction to the loss, physical, emotional, cognitive, behavioral. That is somehow we'll be grieving for some days. Some people start joining their job after what to say 3-4 weeks. They will go for their work, normal life they are leading. Okay, so normal, that's a normal grief. But there's a complicated grief also where they are more intense and longer in duration than expected. Okay, and a lot of risk factors. So with the understanding at different points of time, their life keep on changing. So complicated grief is very important because we need to assess it properly and immediate support is needed. Okay. So symptoms of complicated grief, many things are there. There will be intense sorrow and pain at the thought of their loved one. They'll be just only focusing on that death. Extreme focus on the reminders of the loved one. Okay. Persistent longing or pinning for the deceased. Problems accepting the death. I just remember, just I should say, just 3 or 4 days back only, I had met two persons. One person he told me about one of her friend only. She was talking to me that her friend had lost her brother, and till now she's not normal. It has become a very complicated grief because not eating. I should say more of depression. Okay, she has not accepted that death. That's the main problem. Okay. However, people try to convince her, or what I say, to talk to her, no, it's it. So we were just sharing, me and my friend. And another one was, another grief was a grandmother grieving for the for a baby who is not born. It was an IUD during 8 months. Okay. And I don't know if it is something like she just opened to us and she was just saying, I don't know why I'm talking to both of you, why I opened and told you about this. Okay. It's almost years gone, but still she cannot forget that. Okay. So, and thankfully, people were there to support her. She has not gone to a complicated grief. She is doing her normal things, everything, but still it hurts her. So what she said was, I feel better when I spoke to you people. Something was there that I spoke to you. Okay. So many other things were there. Okay. Number of losses we say, it is coming. Okay. So complicated grief is very important because that bitterness about the loss is not going out. Okay. They become very agitated. They start harming themselves or others, and they go into many other things. So complicated grief has to be, and it says a symptom must last for at least 6 months and cause significant impairment in their social, occupational, and other important areas of functioning to be considered as complicated grief. So, what can the palliative care team do in the complicated? Listen and observe, take previous history, recognize it, and refer for the therapy. Okay. So this is another disenfranchised grief, we say, when loss cannot be openly acknowledged or socially sanctioned, that is at risk, AIDS partners, ex-spouse, step-parent, child, terminated pregnancy and all. Okay. So circumstance where special care may be needed is that is sudden or traumatic death, like what we say, massive cardiac arrest, suddenly the patient accidents, suicide, multiple losses, I said, back to back when the multiple losses are there. This is also one thing. And unsolved grief from prior losses. Already they have been grieving for something, and again one more thing has come to them. So that grief was not resolved, that previous grief, this also is continuing. Children's grief, I'm not going to talk about much about that, but children's grief, based on the developmental ages, it keeps on changing. It can be normal or complicated. And it is unique in children. Okay, symptoms unique to children. Grief in young children and grief in older children are also different. So effects of the grief on the family relationship is like no other. Responsible for protecting the child. Mother and father have unique experiences. Okay, parents usually it is like that. They try to protect their child. How much ever we continue saying about the patient, about the child's seriousness of the illness or anything, they always try to protect their child. This is another thing is about the siblings. Okay, it becomes very difficult for the main person to hold on to the siblings, to make them understand. They have to attend to the sibling needs. They have to attend to the patient's needs. It becomes very difficult, and difficult transitioning back to normal life. That is also very difficult. Making the sibling understanding, making the sibling to understand or to know about what was happening and what happened, that is another problem. The grandparents, when we talk, it is more about, because it's a twofold for them. One side, they are a parent, and one side, the child. So both the sides, when they start grieving, it becomes very difficult. So factors influencing the grief process are survivor personality, coping skills and patterns, history of the substance abuse, spiritual beliefs, type of death, and survivor ethnicity and culture. So these are the grief processes. Okay. So I will just come to one thing. Grief assessment starts at the time of admission or the diagnosis, and it's ongoing and should be ongoing to detect if there is any complicated grief. So our role is provide reassurance and validation of feelings, assessment, and utilize interdisciplinary team. There be a team, nurses, doctors, social workers. Okay, the team should be there to do approach when we are doing a bereavement. So physical assessment of the caregivers is very important. So for the families, provide your presence. Okay. During the bereavement, your presence is very important. If possible, you can call them and ask whether you can see them. Otherwise, you can just talk over the phone also. Active listening, touching, silence, and reassurance is very important. As we say in communication, listen to your patients. Listen to them. That is very important. Follow bereavement phone calls. As I told you, phone calls can help a lot. And if there is any support system nearby, that is also good. In many places, there are youngsters. Okay, you can make a group of youngsters who can support them during this bereavement period. And of course, if you need to refer, do it as it is needed. Normalize and individualize the grief process and of course, actualize the loss, and facilitating living without the deceased is important. So in schools and all, understand what the bereaved child wants their peers to know. See, it happens when a child loses the parent and one of the parents, and when the child goes to the school, at least the peer group should know that what he is undergoing. So this is another thing where the school teachers, they need to know, because in some places, maybe there won't be any support for this child. So he needs guidance, and guidance of what to say and what not to say. So what are the three elements of bereavement? Numbness, disorganization, and reorganization. Okay, different stages are there. Okay, I just thought this was good. Numbness means, as you all know, when there is a loss, suddenly we become numb. Okay, we feel the world has stopped. Nothing will go ahead. I cannot move. I don't think that I'll be able to move without this person. Many things goes. It's just a number. Okay. And everything will be disorganized. But slowly, with the support, we reorganize. Maybe it will take some time. I remember one lost her husband, and she was not normal after that. In the sense, she never accepted that her husband has passed away. So every day it seems that she will get up early morning, she will cook, and 2 o'clock until she will cook. She will do many things which was not very normal, which we do. And at times she will say, get up, go see your father, he's calling you, he's coughing. And it went on for almost about 3 months. Otherwise, when people come, she used to talk and everything. Of course, she told one of the parish priests when she met, she said that when my husband passed away, I didn't cry. Okay. So in fact, the priest told her, it seemed that you were taking care of him for so many years. So that has, what to say, it's just gone like that. But one of a very close family friend made a call after a long time, very close. And he expressed to their daughter that he was not able to make a call because he lost his brother-in-law. And that's the time when he asked, how is your dad and mom? And she told that dad has passed away. Okay. So meanwhile, this wife, she came, she asked the daughter, what happened? She said, the other side, who is that person? So she took the phone, and then we can hear only her cry. Okay, everything came out. And she just told it same, see, daddy has left us from this world. He has gone, and we are all alone. And then she became very normal. So maybe we don't know at what, when, and where they will suddenly open up. So bereavement interventions, plan for a care. If you are going to attend, going to visit the person, plan for the care, because you will be knowing this family since long. Okay, so you can figure out, okay, their relationship, what work they were doing, how the persons in their house, what was their relationship with this deceased person, etc. You will be knowing very well. Attitude, that's also very important. Cultural practices, if possible, what is their cultural practices, what to say. Again, communication is very important. What you have to say. Before saying, at least listen to them, then only talk to them. And if you're the person who were attending them before, that anticipatory grief, what it was, so you can attend to them very more easily, I should say, because if you were knowing this person right from beginning, okay, you will handle the person after that loss also. So the core principles of bereavement care are acknowledge the loss. As I told you, it's not so easy. Okay, it will take time. So why? The loss means how the person died. That's very important. If the person had a very, what is it? I won't say normal, quiet death or not much suffering and this thing, maybe they will feel, okay, he had passed away. And that reality they can accept. Okay. So acknowledging the loss is very important. We need to acknowledge the loss also as a part of that team. Provide support of a practical aid, as I told you, supporting the family with the meals. Sometimes we need to go with the week if we can to somewhere, especially when they are alone. That is very important. Okay, nobody else is there, then we need to be with them. Okay, alongside emotional support like active listening. They may be going on talking repeatedly, they repeat the things that they have spoken to you, but we need to listen to that. Educate, offer information of the grief process and potential emotional reaction, helping individuals understand their experiencing normal. So education is also important because, as I told you, that person asked us whether it is normal. We said it's normal because you are waiting for a grandchild. Okay, eagerly waiting for a grandchild. And when you came to know that the baby has died in just 8 months, 8 months pregnancy, the baby has died. It's something, a big loss where they were waiting for such a thing and suddenly it happens. Okay. So education is also important. Education is not that how we are going to cope up with these things. That is also there. But one more education is this grief process. It's very normal. Everyone grieves. Okay. Empower coping mechanism, that is another thing. How they are coping up, is there any strategy? Many things are there for coping up. Some people will stop going for job. We need to talk to them to continue with their job. And what is stopping them from going their job, we need to find out. And that is why I say bereavement care is very important. How the family is coping up, how the children at home are coping up. Some children, after the death of one of the parent, they won't study after that. They will go into many bad habits. Many things happens. So we need to find out how they are coping up. And if there is any problem, we need to support them. Facilitate connection, encourage connection with friends, families, and support networks. We all know many people say that my friends are my strength. During this grieving period, they were my strength. They were with me. My neighbors are my strength. My family is my strength. So we need to find out about that. Who is supporting this family? some connection. For that purpose only, we say we should have some compassionate community, people who can support them very well, because it's not that easy. So as our palliative care is a very good support, but we need to improve it. So we need more support. Once in a week or once in a month, it becomes very difficult. Okay, so connection with friends and families and other support networks will improve the person in that bereavement period. So a lot of approach is there, different models are there. One is at low risk, benefit from general support from family, friends and all. Moderate risk requires additional support, which may include an individual or some social workers or voluntary groups, or even a general practitioner can help. But when the patient is in a high risk, I'm not talking about patient, about the survivors who are there. As I told you, complicated grief. Okay, they are at high risk where they will needs a professional mental health care from experts. So that is also important care. Before and after bereavement care can begin before and is expected. So we need before, as I told, anticipatory grief. Okay, so before the death itself, we need to start helping them. And of course, it will continue after death. So physical, emotional, and spiritual needs is very important. So as we tell the four domains, physical, psychological, social, and spiritual, that is very important. And palliative care, you all know it's a crucial component. Bereavement is a crucial component on palliative care, because we enhance the quality of life for both the patient and the family, we say. So it should start before also, it should continue also. And if you find people who are still having problems coping up, we need to continue it so that they can get adjusted. Maybe they need some experts support also. Okay, so this has to be integrated into our integrated into our daily work, bereavement care. Practical steps to provide support: reach out, contact the bereaved person as soon as possible. Okay, if you come to know the death, as soon as possible, try to contact them. If possible, you can attend a funeral or any memorial service if they are keeping. Listen compassionately, allow them to express their grief. I told you it could be positive, it could be negative also. Okay, the deceased person, so a nice person, suddenly dies, grieving will be there for a long time also. Okay, but you see people alcoholic or with a lot of problems, the person has died. Okay, it can be both negative and positive. Okay, people may not talk to you very normally. So we need to listen to them, let them express their grief, and of course, listen with empathy and understanding. Ask them what they need. We can ask them how we can support them. Again, it starts before and after. Because why I'm talking of before and after, as I told you about that situation, because she said she wants one picture, one family photo. Okay, because that was her need. So in some cases, people may need something else. So we need to ask, have you seen some people, they are holding still into that specs of the deceased person. They will keep it. And they feel that they are just seeing that person. So these things are also important. Promote self-care. That is another thing. Help them manage challenges like sleep. So now sleep. Recently, I told one person, she said she cannot sleep at home. So I'm talking about some challenges, okay? So I asked, because she lost her husband. So I asked, any children? She said no issue. So, okay. Then I told her, you have relatives nearby, some nearby means some nearby. She said, yes. I said, you can do one thing. Why don't you go and be with your relatives? At least in the night time, you can go and sleep. She said, no, I cannot do that. Then I said, what about your neighbor? She said, she cannot. I said, okay, ask someone to come and sleep in your house. She said, that also, no. Then she asked, can I get some medication? I said, I don't think with your medication you will be able to sleep. Okay, because she's still holding on to the property what she's having. I came to know that after that from their neighbors who had come. They were saying she had got a lot of property and she doesn't want to go to be friendly with anyone around her. So the people are also on the same this one. She needs a lot of support, mental support. She needs someone to sit and talk to her so that she's not able to sleep. So always medication won't help. So the follow-up, healthcare providers, bereavement follow-up phone calls. And if a child has died, meeting with the child's doctor will be very important because that is where the parents will be going always. No? So any doctor willing, they can just, where the child was being taken care, if they go and talk to them, that will become better. Identify support systems. If anybody nearby social groups are there, they can help them and allow time to talk about their feelings and normalize grief. This is Kubler-Ross stages. I'm not going to that. Day by day, what they say. So there are 7 steps, what they say. Shock and denial. That's a time where a state of disbelief or feeling numb. Pain and guilt. Intense sorrow and regrets will be the. Then comes the anger and bargaining. It won't go by step, okay? Just then there will be anger will be there. We'll start bargaining also. Depression can happen. And there is an upward turn, a gradual issue of grieving with feelings of relief, sudden relief. Okay. Reconstruction and working through, and acceptance and hope. And this is not a strict set of rules. Just I told you the grief in a unique each individual we can see at different stages. Okay. Now, before ending with this, I would just like to tell you, sorry. And see, we as a healthcare provider, we are also having grief. Okay, lot of grief. We also undergo a lot of, because some people we say losses only daily, ICUs, pediatric wards and all, multiple losses. Okay, so we also need self-care. We also need someone who can listen to us. We also need people who can support us. Then only we can go on work. So again, what you have written in your short note and what you can write now. Review for yourself. And thank you all. Shiva, Dr.
Thank you, Stella, for that extensive, exhaustive lecture or discussion on this end of life and bereavement support. It's a very, very hard topic for discussion, and as we deal with holistic care, and this is the only area in palliative care where we think about the quality of life of not only the patients, but also the caregivers around them, the families. And I think it is only we, the palliative people, who continue having relationship with our patients' families. And they become volunteers, maybe active volunteers after that incident. Thank you. Thank you very much.
Geeta, just a minute. Can I just ask a question?
Of course.
I'm right now dealing with one acute grief. I don't know how to console the parents. They lost their son due to a tragic accident. I mean, it's not a palliative care case, I agree, but what do we do? How do I deal with that? Hello?
Yeah. I can,
The third
I was just hearing you what you're talking. Okay.
Okay. The other
Uh,
thing is, see,
mm,
there are two types of grief in that family:
mm,
parents and the sibling.
mm,
I know exactly what goes through because I've gone through it myself. I've lost a sibling. And the thing is, at that moment, we are always trying to protect the parents.
mm.
And actually, you don't have time to grieve.
Yeah.
And it's a prolonged, even now, I mean, if after so many years, I still know what it is, to feel that. Very difficult to come out.
But still you are coping up and you're working, you are eating, you are
I'm
doing your work, right?
yeah.
Yeah.
That's not the thing.
So,
But
so
in your
that's what I told you when I started. I told you about the grief. I said it never ends in our life. Okay, my dad passed 20 years back. Still, I sometimes when I think about that, I can say tears will be there in my eyes when I think about him, some time when I had spent with him. That never ends. So now, when you're talking about these parents, first of all, age is very important.
Yeah, they
Uh,
are also old.
yeah,
8-year-old loses a
yeah.
44-year-old son
44-year-old
under tragic
son.
circumstances. It was
So
so
it's very
sudden.
difficult. See, that's what I told you. Talking to a bereaved person, it's not so easy. It's very difficult. Okay. What we can do is listen to them. That is one thing. At one point, see, we can ask them the best things what they have spent with with that son, the best time which they have spent with their son. And what about the other siblings? They are having other siblings also? I
Yeah,
mean, other children. I mean, what I mean is,
just one sibling. They were just two of them.
that's the two
Two
of
children.
them. And what do you, and, well, what is his age? Like, maybe?
No, the son who died was 44, 43. He's got a wife with two small kids.
Oh,
And
mm-hmm,
the sister is there who is around 40.
mm-hmm.
And
Yeah, these people, they need a continuous support. For quite some time, we need to give them a very support. And especially if the person is a working person, okay, got a
there
job,
is not, yeah, that I agree. There is a lot to sort of diversion in the life
yeah,
when you're
diversion in
working.
the life. Yeah, see, they won't get through it. That is for this one because as I told you, it will go for a long time. But we need to give a support also. If any support groups are there nearby who can go and sit and talk to them, this one, social worker, psychologist, someone who can spend a little time with them, talking to them.
Hmm.
Lot of this one, what to say, exploring, so that they can ventilate it. But it takes time.
I know.
Okay, only thing is palliative care means of course we can go, but in a place where I don't know where or what happened, the place and all, but at least can you find out some support group who can talk to them, who can spend a
Yeah,
little time
I
with
will.
them?
I will. She's got her bhajan group and all that.
Group,
So that way, the mother
Bachchan
has
group. I would
support.
like to say, no, I would like to say someone who is very close to them also. Maybe not, no, maybe not a family member or a friend or someone who can sit and listen to them, who was very close to them with their children and all. Such a person.
That
But
will
it should
tell
not
you.
become a, doctor, it should not become a headache also. That's another thing, huh? Okay. Someone
What
really knows what to
I do,
talk to them.
I'm trying to do it. Mm. I mean, I've just been there by being present. That's how I show my support now because it's too early to say anything. It's just a week.
Oh, then we have to give time. It will take a
Yeah,
long
we
time.
have to, yeah, it'll take a
Definitely.
little time.
Yeah, as you said, good that you are at least you are there and showing your support. Same thing, if people can go around and show support, that will be good. Dr.
Thank
Salim,
you.
I'm not a doctor. Dr. Salim, I'm not a doctor. I'm a nurse, okay, a retired nurse.
No, see, in this particular aspect, it is more experience and exposure to situations that matter. It's not your degree. Not at all your
Thank you.
degree. Not at all your degree, Alice. Oh, you call Stella, is it?
Yeah, everybody calls me Stella
Yes.
G.
Okay, okay.
Moderator.
I'm
Yeah, yes, Dr. Salim.
thank you.
Thank you, doctor. Sheba? Hello? Dr. Geeta, can we Dr.
Yes.
Geeta?
Yeah.
Are you there?
Yes, I am very much, very much.
Yeah.
Yes. Can you hear me?
Yeah, I can hear you.
Yeah. You can see me also. Yes. It was a very fruitful discussion. I just wanted to add one small point. Spirituality. Strong spirituality really sees people through a lot of things, especially human histories.
Yeah, but one more thing is they should understand what is spirituality also.
Yeah. Agree.
Because religion and spirituality, we should not
Mix it up.
mix it, and then it becomes
Never
very
confuse
difficult.
one with the other. I'm not at all talking about religion. No religion here. It is just spirituality. That stoic submission, total submission to that, whatever the superpower, whatever you think it is, total submission. So there is no questioning. So when you reach that, I have seen one or two cases. We all come to see different, all of us have experiences this way or the other way. And what I would like to emphasize is we're all dealing with human beings. And human beings, unlike any other species of animals, has the most unpredictable behavior. So in any given situation, how that particular individual, that particular person or the caregiver will respond is
No, we
just
don't know.
anybody's guess. So we're all acting on not 50 different shades of gray, but maybe 100 different shades of gray. So there is no black and white in any given situation. As Stella rightly said, it all comes, it's not the degrees that are important, they are the professional training, the upskilling, all that is important because that will help you treat people properly, correctly, and appropriately. But added to that is that strong, long experience that really goes into by seeing people again and again and again when you come in contact. ബാക്കിയുള്ളവര് എല്ലാരും silent ആയിട്ടിരിക്കും.
In bereavement, one more thing is that's what we said. It should start before also the grief. When they start, we need to come to know what are the events that has happened in their life where they can be forgiving, reconciling. So many things are there like that. And that is also very important because I have come across some persons who cannot forgive at all. And once they came to know about that deceased person, what means that person, what he is undergoing, and after he is dead, before his death, they actually reconciled, and that was how they came out with their grief also. So this all adds up. And that's why in palliative care, we say communication. So I always say not only in palliative care, we need to communicate, where sometimes we will be able to do many things for the patients and the family, of course. Okay, if nothing more, we can conclude. Say good night.
വേറെ ആർക്കെങ്കിലും questions? Any chats?
Excuse me, myself, Dr. Amrita. I would just wanted to ask something like, I've been working as a pain and palliative doctor for the past 2 years. So recently, we've been dealing with a 5-year-old child, and we lost her. So even though it was like an expected case, I mean, it felt it as like a very much heaviness to be deal with it on the while we knew that for about like for the past 6 months it was an expected case, but it was all of a sudden we lost her. But then dealing with such kind of cases on the everyday basis, it just mentally take too much of energy rather than you working up in the hospital atmosphere. What I felt like, it's not like an OP cases, like you deal with the patient, you go to their home and you talk with their parents and grandparents, and you deal with that kind of an environment. And I think that literally take you through a roller coaster ride sometime, and it's not so easy to be said. I mean, I find it as literally difficult sometimes to be go through it. And yeah, even though it take time and days of mine to be get back to it and to be conclude it in such a manner, or to be like give them a positive outlook sometimes. Yeah, I just wanted to add on this point while I gone through it. An excellent presentation, Miss Ali, Stella, Virginia sister. Yeah, thank you.
And that's what I said in the last. Right now, Dr. Geeta, we all need support, right? Okay, where we healthcare providers now we see number of death, but there is no support for us. But of course, I agree. For me, it is like that. Now, whenever I have worked wherever I have worked, I always sit. If any death has happened, I just ask them what happened in the night, who was there, who attended, blah blah blah. These things I ask. Now, at least they can vent out. Now they will be just telling, "Oh, night this happened, that happened. This is the way." Then that vents out. But many times it happens, nobody supports us. Let it be doctors or nurses, nobody supports, especially in ICUs and all. No? Sometimes it's very difficult. One after one doctor seeing 2-3 deaths, one nurse working for 2-3 patients and 2-3 deaths. It's become very difficult. So I mean, and like Dr. Amrita said, children now, we get attached to the children so much now. We may forget the adults, but we won't forget the children. Children, we get attached. 6 months, not even 1 week also, we'll get so attached, and sudden the child goes, we feel very bad. What is a bad, or it's a heaviness for us. So yeah, that's life also. Okay, thank you all so much. And
Yeah.
okay, Dr. Geeta, where are you? So we will say bye.
Dr.
Okay,
Matthew.
Thank you all so much.
Thank you. Thank you. Thank you very much. Thank you. Good night.
Thank you, Stella ji.
Shiva.
Yes, ma'am.
Dr.
Keppularu.
Matthew.